Executive Director, Ms. Florence Villajuanam, to set the scene for this another strategic discussion. Florence, the floor is yours.
Good morning, good afternoon, good evening. Exciting to see you all. Thanks, Enad, for bringing us together on this and organizing on this topic. I had imagined that Enad will start this as his usual way of doing things by quoting from songs. And so because he didn't, I will do it on his behalf. I think Enad and I both believe children. I believe the children are our future. And just by that, we have to do our best for children. I am tasked with setting the scene, so I will try to do that. For GNP+, it is important that the voices, the experiences, and the realities of all people living with HIV are made clear for everyone working in the HIV response, so that we can create collectively solutions based on those lived experiences. A special group remains unnoticed, and some of us must make it our business to keep them on the radar of all of us, and that is infants and children. Many a time, the mothers, women living with HIV, young girls living with HIV, attempt in their own way to get services for themselves and for their children, rightfully so, as they're the first caregiver of children, those vulnerable to HIV and those living with HIV. Additionally, because of the realities of HIV in which many children are orphaned early, caregivers are beyond their mothers. For adolescents and teen moms, sometimes caregivers are grandmothers. In many cases, caregivers are teachers, are religious leaders, are relatives. But statistically, we continue to see children left behind. 620,000 children living with HIV are still not on treatment. We lost 75,000 children to AIDS-related deaths. And studies like those released at the IAS by PENTA, organizations like PENTA, continue to show us the inequalities faced by children in situations where up to over 40% of children admitted with advanced HIV disease die, some at admission in the hospital, many post-discharge. I don't know how many people on this call were in Kigali in 2019, but many of us concerned about the lack of treatment options for children, the lack of concretized action that was to basically create change for children, marched in Kigali, led by groups like Health Gap and others, supported by AIDS funds. We were able to create a movement for children. And from then on, there's been a lot of shifts, policy-wise, research-wise, formulations, so development of treatment options. And I think in the last 5 or 6 years, we've seen a revolution in the opportunities for diagnostics, for testing, and for treatment for children. All of these things have created a significant opportunity that we can be able to use HIV, access treatment, and live quality lives. But children are our future. And as Ace says here, yes, teach them well and let them lead the way. We have so many children who become vulnerable to HIV acquisition, either at breastfeeding, along the way when they're adolescents, and because of our social inadequacies, they get exposed and vulnerable. There are opportunities as well with prevention to ensure that adolescent girls and young women who remain primarily in Africa vulnerable to acquiring HIV are able to access HIV prevention intervention. So today, we are here to talk epidemic control for children, where we do our best, policy, advocacy, community lived experience and action to make sure that children access HIV treatment and prevention products, to end AIDS deaths in children, and to stop new infections of HIV in children. I'm excited that we are joined by our partners from UNICEF and WHO, and all the partners that work on children's issues, and many of you curious to work with us. I've never seen a call that has had so many people interested in joining from the registration to this point. And I hope this is useful for you. This is the start of a conversation with many of you, and I hope we are able to take it forward. Welcome, thank you, and looking forward to creating a better world for our children. Not because it's our work, but because it is our duty to make sure that that happens. Thank you, and back to you, Enad.
Hi, thank you, Florence. Yes, the children are our future. Teach them well and let them lead the way. Show them all the beauty they possess inside. That's Whitney Houston. So thank you so much. And now the most important like the meat of the conversation is like how do we understand WHO guidelines? And we have our colleague from the World Health Organization who will help us understand and go through the highlights of the WHO guidelines. Dr. Nandita Sugandi from WHO will share with us an overview of the WHO guidelines. And maybe we can discuss also later, like how can we address the far-reaching implications of these guidelines in terms of the implementation at the country level. Dr. Nandita, would you like me to share the slides for you?
Sure, that would be great.
Okay.
And I apologize, everyone, that you can see me now. I'm on my phone, but I'm not able to log into the Zoom on the computer. So, Enad, if you don't mind sharing my slides, that would be fantastic.
Yes.
And I just sent a version with no animations, so that should be easier.
I have open my slides.
But good morning, good afternoon, good evening from wherever you're joining, and really appreciate the chance to share some of our new recommendations with you, particularly to those that are focused on EMTCT. I'm just going to turn off my camera, and then we can start with the presentation. But I'm very much looking forward to questions or feedback as well, as we're finalizing the text that will go with these recommendations, and we want to make sure that they're clear and that they're well understood. And as they, we really are intending now to do our best to simplify our treatment recommendations and make them easier to scale up. So with that, maybe we could go to the first slide. Great. So I'm going to start with just a quick overview on the pediatric HIV epidemic. I think many of you have seen these slides from IAS, and we'll follow that with some of the specific WHO 2025 recommendations that have come out of the HIV, hepatitis, and STIs department. But what we really want to focus on today is those recommendations around the use of ARVs for pediatrics, for both prevention and for treatment. Now, I noticed in the chat there was a really great comment about disclosure being the issue. And absolutely, I think none of these interventions with ARVs or diagnostics will be effective unless we manage all the other components of care. And for pediatrics, disclosure is a very big, important one. And I think it's probably worth coming back to that at a later point. But going through, how we're using ARVs in HIV treatment sequencing, and we have to think about infant feeding as well in the context of maternal HIV. Now, this was a request for us to consider that came from the community of women living with HIV, and we really wanted to make sure that we were taking an updated approach to this issue that really respected choice and individual rights. And to accompany that, we've also updated recommendations on the use of ARVs as infant prophylaxis. So again, infant prophylaxis provides that extra layer of protection to the infant while breastfeeding to prevent vertical transmission. Next slide, please. So the first thing I also want to point out is, in addition to the new recommendations, we also have operational guidance that was released at the conference about sustaining HIV, viral hepatitis, and STI priority services. So this really was a structured approach, thinking through the ethics, thinking through the implications, on how to support countries to sustain services in the current emergency. So these are some practical steps around assessing the risk, setting priorities, and adapting services and systems. And this is across HIV, viral hepatitis, and STIs. So this is a stepwise approach. It's not meant to be a one size fits all, but it is meant to be a guide for country programs. So I just wanted to highlight that this is also available online, and the link is here at the bottom of the slide. Next slide, please. So when we look at the global estimates of maternal ART coverage and use that to estimate our global perinatal transmission rates, what we see here, and this is a graph looking from 2010 onwards, that we've had a significant over 56% decrease in new HIV infections since 2010. So over the 15 years, or the last 15 years. But since 2019, we actually have not significantly increased maternal ART coverage. And I want to point this out because this is probably the single most important factor in reaching elimination. And so again, I think we're at a very difficult time now, but we also have a chance to be thoughtful about what's been happening in the past and how do we take maybe a different approach, to improve this number, because I think this is really what it's going to take to move the needle. Next slide, please. Oh, sorry. I think these were the ones that with animation. So I'm going to let you click through to the next slide. Great. And if you could just click one more time. Oh, maybe two more times. Great. Okay, thank you. So I'll also say that we've seen that HIV-related deaths have decreased significantly since 2003. So really over 20 years now, but we haven't made much progress since in the last few years. So we've really slowed. And I think this is an important point when we look at this graph, is not to just look at the absolute numbers, but also look at our rate of change. You could click one more time, you can see that, we had sorry. Actually, we can go to this next slide. We can, if you could go to the next slide, perfect. So we still have high rates of mortality in young children and adolescents living with HIV. And while that's decreasing, it's slowed. So our progress is not what we want it to be or what it could be. And I think this is really why we wanted to look at how do we now adjust our approach to reach those that are most vulnerable. And you can see here in this graph we really have the highest rate of mortality in the youngest age group, so those that are under the age of 5. But when you look at these other age bands as well, the green in age 5 to 9, 10 to 14 in yellow, and red we don't see as much change, right? So we haven't seen as dramatic change. So this is just a reminder to us that, again, it's not necessarily the absolute numbers, but understanding overall what's happening and how quickly we can get to our goals. Next slide, please. Okay, and so with that, I'm going to move to the new recommendations. Next slide. Great. And so these are really what has been published and are now online, and were launched officially at the Kigali conference. But again, it's really great to spend more time going through these recommendations with smaller groups so that we can have a discussion. So we have new recommendations, and many of you know we have recommendations on dual treatment for HIV infection, lenacapavir as PrEP, TB preventative therapy, HIV service delivery, advanced HIV disease, Mpox, and STI screening. However, the recommendations I want to focus on, given that this discussion is around EMTCT, is the first four here that are in the box. That's the new dosing for neonates and infants, which is not a recommendation, but enabled us to make a recommendation. But this was from some very well-designed clinical trials to help us figure out the safest dosing for young infants. ARV recommendations for treatment sequencing, and this is applicable for both children and adults. Breastfeeding in the context of maternal HIV infection and infant postnatal prophylaxis. And there is a barcode here, and that will link you to the WHO site, where all the recommendations and guidance documents are available. Oh, next slide, please. Oh, I think you could go to the next one. Great. And I'm just going to have you click through until you get to a red box at the end of the graph. Perfect. Thank you. So this is how our guidelines have evolved for initial ART over the years. So many of us remember, I think the first guidelines were 2002, but I've started here at 2006 because this was really when we started using sort of a modern day idea of triple drug regimens. And we used, specifically, we used to recommend either D4T or AZT with either 3TC or FTC, and use NRTI backbone, so nevirapine or efavirenz. And that was our first line for many, many years. But over the years, we've progressed towards simplified and less toxic regimens overall. And since 2018, dolutegravir-based regimens using either abacavir or tenofovir have been the preferred initiating regimens for all populations. However, the caveat there was they were all populations over the age of 4 weeks, because we did not have a dolutegravir dosing for the youngest infants, for neonates, or those that are 1 month or younger. Next slide, please. So this is now what we have. This was work done by the Pediatric ARV Working Group, and some in clinical trials that really were groundbreaking in that it really represented sharing of information around groups, and really making sure that we were focusing on what it took to figure out this dosing. And so what we do have now is, with new pharmacokinetic and safety data on dosing, we now know that we can use dolutegravir-based regimens for initial treatment across all populations. So even those youngest infants who may be diagnosed shortly after birth, we now have dolutegravir-based options for them. Now, the tricky part to this is that the dosing in the first month of life changes. So it started at 5 milligrams every other day for 2 weeks, and then increased to daily at 2 weeks of age, and then afterwards following the infant dosing table. This is something we want to explore a little bit more to make sure that when mothers or caregivers are receiving instructions on how to dose, they're receiving instructions that are easy to follow, and helpful. So we do now have, and to us, this is really good news, because for until now, we had raltegravir for use in neonates, which was a difficult formulation to use and very expensive for programs. So now with this dosing schedule, we actually have dosing using the available formulation of the 10 milligrams dolutegravir that's scored, as well as the abacavir 3TC dual regimen, or dual tablet. We also have more data to inform the dosing of PALD, which is the 3-drug combination for treatment in children. And this is appropriate. And previously, we could dose it from 6 kilos onwards, but there were those smaller infants from 3 to 6 kilos that we could not. And so now we finally have that dosing. And so we really can say that from 1 month and 3 kilos onwards, there is only one tablet that's needed in multiples to deliver effective pediatric treatment. So this is the first time we've had that. So it's been very exciting for the ped space. And we're hoping this helps us to scale up treatment. Next slide, please. So in terms of what's changed with our WHO recommendations, the what to start or those recommendations for the initial regimens aren't changed. So we're staying with tenofovir and DTG as our preferred initial regimen for adults and adolescents, and using abacavir, 3TC, and dolutegravir for infants who are for infants unable to take tenofovir. I'm sorry, I'm Enad, is that you?
No, I just muted everyone,
Oh,
so you
sorry.
can go ahead.
Okay, sorry.
Sorry, apologies.
No problem. But sorry, I just can't see everyone, so I'm trying to follow along. So the one place this does change for us, though, is again in the neonatal population. So we now again have more harmonized dosing and ARV recommendations across populations. Next slide, please. And next slide. So, but when it comes to treatment sequencing, and here I want to point out that I'm trying very hard to not say first and second line, because I think over the years we've come to the realization that after years of optimization, of changes, of that thinking about first and second line sort of has lost its meaning. So we're really moving towards thinking about um, initiating regimens, particularly with integrase inhibitor based anchor drugs, and then sequenced regimens for what is needed after failure. So the two recommendations that really have been developed, number one, is that darunavir and ritonavir is now the preferred boosted protease inhibitor if a protease inhibitor is needed. So we're not talking about second line, but we're talking about those circumstances where there may be dolutegravir failure and we need another anchor drug. Now, atazanavir or lopinavir with ritonavir are still alternatives because there are specific cases, particularly in young children under the age of 3, where darunavir can't be used. But the second new recommendation that also goes along this has to do with the NRTI backbone. So the preferred nucleoside reverse transcriptase inhibitor, or NRTI backbone, for initial and subsequent regimens is tenofovir or tenofovir alafenamide fumarate, or TAF, with lamivudine or FTC as the preferred NRTI backbone for both initial and subsequent ART for adults, adolescents, and children weighing more than 30 kilos. Now, this includes individuals previously treated or exposed to tenofovir or zidovudine, because we know there are some people who are still taking zidovudine as part of a second line because they had previously failed a tenofovir or a abacavir containing regimen. And at this point, based on the Odyssey studies and several other studies that were done that looked at what we called recycling NRTI backbones, actually demonstrated that it worked quite effectively. So again, I think moving away from older drugs that are more toxic and looking at what we can do now with the drugs we have available, I think this is a huge difference from the paradigm we previously had that called on, that once you fail, you switch all 3 drugs or you switch at least 2 drugs. And now we've really changed that so that we're maintaining an NRTI backbone. And for children, that backbone could either be abacavir or TAF, as there are TAF formulations that are available to dose children 14 kilos and above. So this represents a pretty big change in how we think about sequencing. Next slide, please. And what this really does is simplify our tables. So many of you are familiar with the WHO tables that go through the different regimens that are recommended for initiating as well as after treatment or initial failure. And now what we really have is a much more streamlined approach to this that maintains drugs in subsequent lines of therapy. So this means that we need fewer products to deliver across all populations. Next slide, please. And so with that, I'm going to move in now to really the focus on EMTCT recommendations and what has and what hasn't changed. So one thing I will say is that one thing that has not changed is our good practice statement from 2016, which is that ART should be initiated urgently among all pregnant and breastfeeding women living with HIV, even when they're identified late in pregnancy or postpartum, because the most effective way to prevent HIV vertical transmission is to reduce maternal viral load. So we really, again, want to stress this point that we put in place infant prophylaxis and other interventions, but really the most powerful interventions, so the most effective, is maternal ART. But next slide, please. Oh, sorry. And you know what? I think I'm also a little bit behind. So you're ahead on the slides. If you could switch to the next slide. So again, our good practice statement has not changed. If you could go up, there we go. But we also, again, this is where we heard from the community that there were some really different experiences in across countries. So we know that vertical HIV transmission risk has declined significantly because we've had better ART, wider access to ART, maternal viral load monitoring, and the use of ARV prophylaxis. But we've also, we have not covered all women. So we really haven't reached 100% of women living with HIV. And so and out of all of the 84% on ART, 94% were virally suppressed. So again, we see where these gaps are. We know very well where these gaps are. Now, in 2023, WHO was able to affirm that those people living with HIV who have an undetectable viral load have zero risk of transmitting. So this is really where we came up with zero equals zero, right? So zero viral load is a negligible risk of transmitting. Now, the question that came to us, though, was, does this apply in the context of vertical transmission? Does a suppressed maternal viral load significantly reduce or eliminate the risk of transmission? And for this, we had to look at a systematic review that reviewed all the studies on on postpartum transmission that was done. But we also recognize that out of a number of countries, many countries do not recommend breastfeeding, or actually recommend avoidance of breastfeeding. And in some cases, we've learned that there are mothers who are criminalized or stigmatized if they choose to breastfeed. So this is really what we looked at. And I'm going to go to the next slide, which shows you the results from that systematic review we looked at. And here we can look at a pooled analysis of the of all the cases, and you can see here in the fourth column the number of events. So how these were large studies, but and you can see in person month. And I'm sorry, but we could see the number of events are very low. And when we look at the number of events less than 1,000, it's really almost negligible to this. So with the next slide, what we really learned from this, to the next slide, please, is that absolutely this confirms that higher maternal viral load is significantly associated with postnatal HIV transmission, and again, confirms that a lower maternal viral load significantly reduces risks. But however, there were, I won't say several cases, there were 3 cases of postnatal transmission when there was a documented maternal viral load of less than 50 copies. So in some sense, while this is almost a negligible risk, it's not a zero risk. And for this reason, what we move towards is really more of an evolving guidance that encourages shared decision making for those women who desire to breastfeed in those settings where breastfeeding is not permitted. Now, in this context, there are very few studies about this in the context of first-line integrase inhibitors. But that said, we'll say that we know that these are very potent formulation or drugs. And so very likely, again, we're very confident that using maternal ART is a very effective way of preventing against vertical transmission. So our new recommendations, if you go to the next slide, is for in settings where replacement feeding is the official policy and where the national program recommends replacement feeding, mothers living with HIV who are receiving ART and have suppressed viral loads should be offered the choice to breastfeed and be supported in their infant feeding choice. So that is for those settings or those programs where replacement feeding is an official policy. Now, in all settings, enhanced community and facility-based interventions may be offered to mothers living with HIV who are breastfeeding to support ART adherence, improve retention of mothers and infant pairs, and optimize breastfeeding. So we felt it was really important, again, knowing how critical maternal ART and adherence is to make sure that we have a clear recommendation for support. Next slide, please. Okay, and then with that, we're going to go to postnatal prophylaxis for the infant, which again is that extra layer of protection. Now, the recommendations that were previously in place had been developed in 2016, but since then we know highly effective dolutegravir treatment has been scaled up. It's safe to use in pregnancy and breastfeeding. We also now have that new safety and pharmacokinetic data on ARVs, which allow us to dose newer drugs in infants from birth onwards. We have alternative studies. Previously, we had only had studies looking at AZT and nevirapine, but there has been at least one more study looking at alternative ARV options. Again, on the horizon, we have more exciting drugs on their way, right? So that really hold the potential to provide more durable viral suppression. And we're thinking about this as well for pediatric populations. And lastly, I'll say that because of treatment optimization for treatment, we've largely eliminated now the use of nevirapine and AZT for all treatment recommendations. Now, this is with the exception of the neonatal population for neonatal prophylaxis, right? So I'm just going to go to the next slide where I have the previous set of recommendations. I'm not going to read through the whole thing, but what we really had to do is sort of tease out what are the different domains of infant prophylaxis. And the first thing the first thing that we have to think about is the transmission risk. And so I think I'm missing this slide, but one of the things that has not changed. Oh, sorry. Actually, you know what? Could you skip ahead to the next slide and the slide after that? Perfect. Thank you. Sorry, I think my slides were a little bit out of order, but what I wanted to say is the first domain to think about is transmission risk, and this is something that we have not changed. So risk stratification, which is determining whether an infant is at high risk or low risk of vertical transmission, really starts around the time of delivery. And that determines whether we use high or low risk prophylaxis. Again, maternal viral load is the most important factor, but we recognize that programs that may not have routine viral load readily available, that there may be alternative strategies to figure out, because what we're really trying to determine is if an infant has a high risk of prophylaxis, there is one, or high risk of transmission, there is a high risk prophylaxis recommendation, whereas those that have very low risk because of maternal viral suppression, there isn't a need to expose those infants to many drugs. And now, Inad, I'm going to have you go back 2 slides, and I apologize for this. Okay, perfect. And just to say, one of the reasons I didn't want to spend too much time on the previous WHO recommendations is really because there's currently, I think our standard of care is very variable across countries. I'm sharing with you, this is a policy review that was done in 2021, and since then some of this has changed. But what you can see here is across these countries had very different policies when it comes to recommending infant prophylaxis. There are some countries that consider all exposed infants at high risk and provide either AZT or nevirapine. There are others that continue to perform risk stratification. There are some countries that are providing multiple drugs throughout breastfeeding. So again, it's very variable across countries. And again, this is where we're hoping that we can now streamline and move towards something that we all can use together. I am now going to have you go back to it's slide 27. So it's the third slide after this one. Thank you. And so with that, these are our new recommendations for infant postnatal prophylaxis. So those infants who are not at high risk of acquiring HIV should receive 6 weeks of infant prophylaxis with a single drug. Nevirapine as the preferred choice. Nevirapine, we have a long track record of using it. It's available in formulations that are appropriate for infants to use. And we have a lot of evidence on the safety and use of nevirapine as prophylaxis. Now, dolutegravir or 3TC are alternative options. There's one study looking at 3TC to prevent transmission during breastfeeding, and there are no studies of dolutegravir as prevention for postnatal transmission. However, there's an understanding that what is the dosing that is appropriate for treatment will also most likely be appropriate for prevention. We wouldn't seek out a separate dose. And then also it's also again more likely to be available in the future as we have less use of nevirapine and more children using dolutegravir-based regimens, and it simplifies and again reduces unnecessary drug exposure to those infants who are at low risk. But for those infants who are at high risk, what we are now recommending is a 3-drug regimen with abacavir, 3TC, and dolutegravir as the preferred option. So that is when an infant is first recognized as high risk, they should start on a 3-drug regimen, which really serves as presumptive treatment. Now, those breastfeeding infants who complete 6 weeks of that 3-drug regimen can then follow with a single drug prophylaxis for the remainder of breastfeeding or until the mother achieves viral suppression, whichever comes first. And again, nevirapine being the preferred choice. So again, with this, we hope that this clarifies management of infants, whatever they are identified as being at risk. And so we are not unnecessarily exposing infants who are at low risk to multiple drugs, but that we're also making sure that we are doing everything we can to provide safe prophylaxis to those infants who are at high risk. So next slide, please. So the implications of this now is that, again, in the context of INSTI-based maternal ART and maternal viral suppression, we have much more confidence now that the risk of vertical transmission is minimal. So this means now where replacement feeding is the official policy, if mothers are on INSTI-based regimens and have viral suppression, they should be allowed the choice to breastfeed. And again, that is respecting maternal choice. But in all settings, those breastfeeding mothers living with HIV should be provided support to adhere to treatment, promote retention of the mother and infant in care, and optimize infant feeding. And then lastly, our infant prophylaxis recommendations provides that additional layer of protection during potential periods of maternal viremia. So that is single drug prophylaxis provides protection against vertical transmission and may be extended to prevent HIV infection in exposed or in breastfeeding infants during periods of maternal viremia. But triple drugs may be used when an infant is first recognized, and this serves as both enhanced prophylaxis as well as a form of presumptive treatment until we can rule out infant infection. With that, I'm going to have you go to the next slide. And I think it's important to say that our infant diagnosis algorithm has not changed as well. And this is really critical. This is how it comes together. Because for those infants who are at high risk, we want to make sure that once we can rule out infection, we know that they no longer need presumptive treatment and that a single drug is protective against transmission, even in the context of maternal viremia. So I just want to stress again that our infant testing algorithm is still critical, and it's the only way we're really going to know if we achieve EMTCT. So we recommend testing where a value. So in some countries, they are testing at birth, but the most important test is at 6 weeks, at 9 months again, and then any time an infant presents as sick. And then lastly, at the end of breastfeeding, at the end of exposure, a confirmatory test, a final diagnosis is made. So this really means, this is the importance of maintaining that mother and infant pair in follow-up. And I'm going to go to the last slide now. So again, our new recommendations further simplify the use of ARVs for pediatric treatment sequencing and prevention of vertical transmission. When a boosted protease inhibitor is required, darunavir-ritonavir is now the preferred option, with atazanavir and lopinavir-ritonavir as alternatives for cases where darunavir can't be used. Abacavir and 3TC or TAF, FTC, could also be used as the NRTI backbone for subsequent regimens in children less than 30 kilos. And again, this includes those with previous failure on AZT. Now, in the context of modern ART, programs that have recommended the avoidance of breastfeeding in the context of maternal HIV may offer breastfeeding as a choice to mothers on ART with viral suppression. And single drug ARV prophylaxis for 6 weeks with nevirapine is preferred as the infant prophylaxis for those infants who are at low risk of transmission, with dolutegravir and 3TC as alternatives when nevirapine is not available. But triple drug regimens for 6 weeks is recommended for those at high risk whenever they are identified. And then after HIV infection is ruled out, can be followed by a single drug as prophylaxis for an extra layer of protection if maternal viremia is a concern. And so those are our new recommendations. I think we really hope they're clear and simplify the drugs that are needed and the way programs approach treatment for both mothers and children. And with the last slide, I'm going to share again, there are different technical products available. And you can find them here on the barcode here. But with that, I'm going to say thank you so much again for the opportunity to share these with this group. And I'm looking forward to the questions and comments, and we'll also go through the chat as well. Thank you.
Thank you so much, Dr. Nandita, for sharing all those points. And thank you for specifically presenting the implications of these guidelines in different settings, because I think that's important. Like, what are we expecting? What are the expected implications in the guidelines? Something's wrong with my background. But anyway, we would also like to encourage everyone to make use of the chat. Thank you for muting your microphone. To make use of the chat for any questions that you have. We will have a specific question and answer after all the presentations are done. And I also encourage Dr. Nandita to engage on the chat room for the questions that our participants may have. We also want to thank WHO for the kind of partnership that you are showing, the partnership with people living with HIV networks that you have showing or have started to work with in terms of making sure that the processes are also community-led. So GNT Plus has been commissioned by the WHO earlier this year to organize values and preferences surveys to inform the treatment guidelines, including the guidelines for AHD, for service delivery, and for children. Now, there are a number of guidelines that has been launched during the International AIDS Conference. And we are trying to make sure that all of these guidelines will be shared with our PLHIV networks in the coming weeks through our convening or through any other discussions. We would now move forward. So please do send in your questions in the chat. Please feel free to engage and to discuss with your co-participants in the chat. But we will move forward with our discussions. Now that we have these guidelines launched, we are expecting that this will be implemented at the country level. But what are the considerations in the implementation of the new WHO guidelines? So we have our colleague from UNICEF, Dr. Ruslan, to address some of our points. how do we strengthen health systems, emphasizing on the integration of EMPCT into the broader maternal MNCH and primary healthcare platforms? And what are the approaches to institutionalize community engagements, meaning that the community, especially the women living with HIV, have stronger roles in terms of the planning and monitoring of these initiatives at the country level? Dr. Islan?
Yeah, thank you. Yeah, so that's very great. So, and I would like now to start my presentation. Can you see it?
Yes.
And do you see it as a screen, you know, as an open screen? Yeah, I don't know.
Oh, we see it as a slides, not as presentation.
Start again. Okay, can you see it now better? No?
Yes, thank you.
Okay, so thank you so much, you know, so for inviting me to have this talk. And so it's and I think Nandita did my job much easier. So one thing when I want to start with after what we just heard, that we can see and observe, you know, how the new drugs coming out. So they become more potent, they become easier to take, etc., etc. But one thing remains constant, you know, so we see it across different systems, across different countries, so that still the most active drug, so the most potent drug, is the activity of the civil society. And that's when it's enabled, and that's when it's applied. So then all artists works. We don't have civil society active. So if the prevention work and treatment is not democratized, so then it will not reach the most vulnerable population. So then it will not reach its goals. So we'll have the systems, but systems not necessarily will serve people who are most in need. And from that, I want to present my first slide, which will outline actually the three key considerations of the WHO guidelines. So, and the number one we'll talk about the integration. Number two, we'll talk about the community engagement. And number three is rights and gender equity. And we all know that the civil society play a critical role in EMTCT efforts. So it's fostering collaboration, advocating for human rights, engaging communities, building capacity, monitoring, evaluating programs. There's a long list. So that's what we'll talk. So how these guidelines, you know, will help civil society to do its job. Because we observed, you know, when we started the work on elimination of multi-shot transmission, validating especially, so exercise. And then we added to it, to HIV, we added syphilis and later hepatitis. We've seen, you know, the big gap actually, so between those. We see how much more progress made with HIV, so compared to other diseases. So syphilis, for example. And then, so that comes to the point, you know, so we cannot do just only one disease. We need to come to the integrated package approach, how to make civil society so works, so to help, you know, so to eliminate other congenital infections. And that comes the point of the integration. So what we're talking about, so that quite often we observe the systems which are quite vertical and quite parallel. So, you know, in some places, you know, we see strong systems, so for example, for prevention of HIV, but very weak systems in syphilis, or vice versa, or hepatitis. Because where the system is strong, so, and the civil society is vocal, so we see the very bold response. For example, Egypt. So many of you know that Egypt eliminated hepatitis C, and they talk about validation of elimination of hepatitis C. And that's where was also a big push from civil society, because they see it's as a public health threat, so hepatitis C. So how to go across different systems, how to train primary health care workers to work effectively together with the civil society, so to address the problems. Because today we see, for example, that immunization clinic or family planning services, they work their way. So how to make them work together with the civil society groups, working in outreach in HIV. So how to make them together working so to address the issue of prevention of mouth-to-child transmission, of congenital infections. And there are very good examples, coming from the countries, because by now we've seen, many exercises on validations took place, and there are already I think it's almost 20 countries now close to which have a validation certificate. So, and I wanted to talk about some countries which already eliminated, had got the certificate of elimination of mouth-to-child transmission, or those who are already in the process of a pipeline, right? So we talk about Thailand, Malaysia, we talk about Brazil, so Ukraine, many other countries, right? And what we see that the collaborations between civil society and governments, with local administrative organizations, private sector to implement prevention programs, been really, really, really instrumental. So when it comes to the validation, it's interesting. So that one of the main challenges, actually, first countries often. So it's exactly how meaningful was engaged civil society in the elimination effort. Can country prove, that when they did the eliminations, that civil society groups participated in every stages, of the process? And if that's not proven, so the country don't get the certificate. So here we come to the institutionalizing of community engagement. So we're not talking about just ad hoc interventions, but we talk about the system. So how the civil society advocates for the right of women, children, marginalized populations, what the platforms are given in the country for civil society to do that. For example, in Brazil, organizations like National Movement of Positive Women Citizens evaluate human rights and gender equity aspects during the certification process. So there's a lot of space, where can talk, and give it to the civil society groups, to evaluate and to validate, that activities, that promoted by different branches, of government organizations. So we're talking about putting the central human rights and gender equity, how they will be in the center of the validation. So, because we have a number of healthcare workers across different systems, maternal and child health. But how many of them actually been trained, so how many of them understand the stigma, right? How many of them understand gender-based violence? We talk about, like here, the new guidelines that will show about breastfeeding, so how they can be implemented, without understanding those. Because if we recommend women, so for example, okay, do the breastfeeding, so which replacement breastfeeding. So how it can be taken by the community, by their local circumstances? Would they be able to do this actually? So because maybe for them, together with the civil society can decide, so what is the best policy, in the country to be. So based on the environment, based on the context, and what are the options so are given so to women. So that's what we thought. The civil society group participation is critical. So, and we have women so who are actually spotlight, by the civil society, so that current systems are not effectively addressing them. And in different places, so it can be different groups. In some places, it can be women who are using drugs. In other places, migrant women. So in other places, it can be communities, which live like in Brazil. So in Amazon, so we also, on islands, it's remote areas, how to reach them out. And the solutions are there. So basically, with the communities. So how communities influence national policies and helping those women so to access these new guidelines and new recommendations. So that's the critical piece. So in summary, I think I made my presentation short intentionally so because I think we'll have a space, for questions and answers. So and there we can discuss together with you, of different aspects, how these guidelines can be translated basically effectively so and operationalized in the countries so that it will be not too late. So, and it will be timely engagement. So of the civil societies of the countries from the first kind of steps in the implementation. So not to delay and not to repeat the mistakes from the past. So in this, I would like to thank you, and I will look for the questions and answers from you. So and so we can continue the discussion during this webinar. Thank you.
Thank you so much, Dr. Raslan. And I think the points that you have shared are very essential. We're taking note of that. And the examples from Thailand, from Malaysia, and from Brazil are an examples that the community engagements should really be, not should, must really be at the center of the response. But again, the challenge is how to translate those policies and guidelines at the country level in different contexts. And I hope we can have those discussions later on. Thank you so much for your presentations. It's really insightful. And it kind of like give some more insights on how we can translate the WHO guidelines into practice at the country level. Thank you so much, Dr. Raslan. And now we are moving forward. We're going to the 12 countries breakthrough policy report. So we have, like, when we talk about women and children and young girls, we maybe Dr. Raslan, you can stop sharing, or I can start sharing. We have.
If you can.
Oh, sorry, that's okay. I can share. I'll do this. I think that's okay now. Now, when we talk about children, women, and young girls, we should also talk about the 10 and 10. What are the breakthroughs in terms of the leadership of women? What are the different approaches in institutionalizing community leadership and engagements? And we have Dr. Lazina Muna from UNICEF to share us some highlights on the recently launched breakthrough policy report and share with us some insights on building leadership and tackling barriers at the country level. Dr. Muna, the floor is yours.
Thank you. Thank you so much for the opportunity, and a warm congratulations to my previous presenters for their very critical, important points and issues that they have raised. And a very good morning, good afternoon, evening, our wonderful community network colleagues and partners, wherever you are. I'm mindful of the fact that this conversation is taking place in the shadow of mounting challenges, where an abrupt pause in financial aid, followed by a widespread closure of HIV programs and shifting development priorities, threatening to unravel decades of hard-won progress. These cascading setbacks are felt most acutely by those already on the margins: children, adolescents, and pregnant women living with or at risk of HIV. Next slide, please. Against this backdrop, these are the two questions that I have been posed to. I will be presenting some of the key findings of the report. It's almost done. We spent 2 months collecting various inputs from a wide range of stakeholders. And I'll also pick one particular comment, given the time. I felt let's do justice, diving deep. So we will present that particular point out of the report to share why community institutionalization and their leadership is critical in implementing some of the policy recommendations and suggested actions the report present to you. Next slide, please, Inad. So the implications of service interruptions are profound. You all know it, but the evidence shows that nearly 1 in 5 infants under 1 year of age who experience treatment interruption does not survive. We are therefore continuing a critical moment to child survival. And against this backdrop, we have a Global Alliance Breakthrough Policy Report. In short, throughout the presentation, I will refer it as policy report. So it offers a comprehensive analysis of the policy landscape across the 12 Global Alliance countries. For those not fully aware of the Global Alliance countries, they include Angola, Cameroon, Cote d'Ivoire, Democratic Republic of Congo, Kenya, Mozambique, Nigeria, South Africa, Tanzania, Uganda, Zambia, and Zimbabwe. So the 12 Global Alliance countries land policy landscape was uncovered. We looked in depth what are some of the relevant policies that will support ending AIDS in children. We also looked at a wide range of issues very critical to attaining these goals, identifying social, cultural, and gender-related barriers. And we also frame them within the Global Alliance's Pillar 4, which looks at societal barriers. The report also provides a renewed urgency to strengthen enabling right-based policy environment in the alliance countries. So we really gave it a bit of deeper dive for each country, and you will understand where the country stands when you look at a particular policy within the framework of the global alliances. Next slide, please, Inad. The report is developed based on the understanding that achieving 95 targets, where 95% of people living with HIV know their status, 95% of those diagnosed are on treatment, and 95% of those on treatment have viral suppletion, will be unattainable without first addressing the 10-10-10 Global AIDS Societal Enabler Targets. Established in the 2021 UN Political Declaration on HIV and AIDS and the Global AIDS Strategy 2021 up until 2026. As you may know, these 10-10-10 societal enablers targets include reducing HIV-related stigma and discrimination to less than 10%, ensuring that fewer than 10% of people living with HIV face barriers to accessing essential services, and ensuring that less than 10% of countries have punitive legal and policy environments that impede the HIV response. While the global 10-10-10 targets mark an important step towards addressing stigma, discrimination, and punitive laws that hinder effective HIV response, the framework does not fully account for the unique vulnerabilities of children, adolescents, and pregnant women living or affected by HIV. So these populations face distinct challenges that are both age and gender specific, yet are often overlooked in the broader policy response. Children and adolescents, unlike adults, as you know, rely on caregivers to access healthcare and navigate complex legal and policy environments, including age of consent laws for HIV testing and treatment, disclosure guide regulations, and guardianship protocols. We know disclosure has a new guidance from WHO. And adolescents, particularly girls, face additional structural barriers rooted in gender inequality. So these include limited access to comprehensive sexual and reproductive health services, early and forced marriage, and exposure to gender-based violence. Societal norms and deeply embedded gender roles continue to shape the behavior of caregivers, health providers, and young people themselves, undermining the timely access to HIV prevention and care. So with these considerations, we placed an adapted 10-10-10 framework that you are looking at on the screen, aligned with Global Alliance's Pillar 4 and grounded in the principles of Convention on the Rights of the Child at the core of this policy report. The report is also grounded in the understanding that while biomedical advances have transformed the landscape of HIV prevention and treatment, as Dr. Nandita presented, health systems and policy environments often fall short in translating these breakthroughs into accessible and equitable care, especially for children and adolescents. So the report also underscored with that very understanding that if we fail to address stigma, discrimination, lack of legal protection, gender inequity, and fragmented cross-sectoral collaboration, people living with HIV, particularly the most vulnerable ones, will face significant heightened risk of dying from AIDS-related causes. Importantly, the impact of biomedical interventions and policy reform becomes statistically and practically meaningful only when these structural and social barriers are addressed collectively by all of us. Next slide, please. So what are these adapted 10-10-10 within this framework that I have just presented to you? Let's unpack. So the very first 10 includes strengthening legal and policy framework. We are not really far removed from the original 10-10-10. We just simply added those specific to children. So we are proposing here that less than 10% of countries have laws and policies that restrict or limit equitable access to essential HIV testing and treatment services for children, adolescents, and pregnant women. We made the horizon or landscape for children a bit wider. So underneath, you'll see some of the policy areas we identified that we must focus on to achieve the first 10 includes universal birth registration policies, that they are anchored in the mandate of the National Civil Registration Authority to ensure legal identity. We are proposing national policies are in place to uphold the constitutional right to health, guarantee universal health coverage, and ensure no-fee access to primary health care. We are proposing national policies as well as HIV testing and treatment guidelines are aligned with international normative standards and are designed to standards and address legal policy and societal barriers that impede access to HIV services. We are also looking at national policies provide for the availability and accessibility of health services at all levels of the health system through decentralized structures. And last but not least, we are requesting that national guidelines aligned with normative standards supporting the integration of all health services within the primary health care. Next slide, please, Inad. Thank you. And the second 10 focused on stigma and discrimination. We are proposing driving down stigma and discrimination to improve health and well-being. So we are suggesting that less than 10% of children, adolescents, and pregnant women living with HIV experience stigma and discrimination, under which we are focusing on 3 issues. National policies contain provisions to prevent and address stigma and discrimination. National policies make special provisions for disclosure of HIV status, together with along the line with the new disclosure guidelines of WHO, that national policies include explicit safeguard to uphold the rights to privacy and confidentiality of individuals. Next slide, please, Inad. And in the next slide, what we are proposing is really coming from our third 10 that we have focused on gender inequality, but what really matters for children and adolescents. Within that, we are proposing ending early marriage, pregnancy, and gender inequality, and violence for every girl and women. Less than 10% of girls, as you know, and young women experience gender inequality under these third 10, resulting in triple threat of early pregnancy, HIV, and gender-based violence. So we are proposing strengthening gender equality within the national legislation and policies. There will be provision for child marriage and to prevent, as one of the resources or way forward, to prevent early pregnancy. We are proposing national policies support retention of girls in secondary education because we know the impact of education on HIV prevention. We are also proposing policies include social protection for vulnerable adolescents, especially girls, and national legal framework criminalizes gender-based violence and harmful practices. The next slide, please. This particular slide gives you a bit of glimpse, the large number of policies that we looked at that we felt that deeply connected to all the possibilities of ending AIDS in children by 2030. So you will find many of the guidelines, policy areas, strengthening various legal frameworks. You will also see overall like universal health coverage and other big landscape policy space included here for a quick snapshot for you all. But of course, the policy report has deeper dive and much more analysis on each of these policies in these 12 Global Alliance countries. And I really encourage that you read to understand what they tell you. Next slide, please. Now, coming to the question that GNP Plus posed me to respond to, I thought that perhaps out of many recommendations that the policy report has, integrating community health workers into primary health care for decentralized people-centered service delivery could be one of the way forward to make sure that we continue to strengthen EMTCT guidance that we are discussing today, but at the same time, strengthening policy support for many other areas where we need to work cohesively in various specific countries. The proposal here is that we formalize and integrate community health workers, especially those living with HIV, into national PHC systems as essential service providers, not just volunteers. So that's a very clear recommendation. So we'd like to move forward within the conversations that we are having. We are also going to see that we advocate for CHWs to represent, to ensure community perspectives are embedded in health system to strengthen various efforts. We'd like to suggest that we promote inclusive recruitment strategies that prioritize people living with HIV as community health workers to strengthen, especially where we are providing service delivery for children, adolescents, and women living with HIV, and strengthen trust between communities and the health-seeking population, and reach that communities with that very trust that only people living with HIV can ensure. Next slide, please. Some additional suggestions out of the policy report that we partner with multiple ministries, not just one, like only health. We are also proposing that we mobilize adolescent-led network to co-create differentiated service delivery models. We are going to push for integration of HIV services with crash transfers, school-based programs, and GBV response. These are the three critical areas that our literature and various program success continually pushing us to take the direction on. We are also looking at community dialogues and media outreach. So a combination of on-the-ground community dialogues as well as national media reach to make sure that all the success of this advocacy is really multifold. Scaling up of holistic multisectoral interventions based on the pilot data, mobilizing adolescent networks and South-South learning as some of the additional work to make sure that these advocacy actions are truly fulfilled. Next slide, please. Now, a very quick slide. I know how enormously resourceful GNP Plus is. I really not I didn't feel comfortable to suggest anything when it comes to advocacy. You guys really the golden mark to show how advocacy should be done. If you allow me, being very humble, I am proposing these 4 steps for advocacy. Understanding the issue inside and out is the core fundamental of any advocacy to build your knowledge base. A report like a policy analysis will give you plenty understanding what it is, where we are with a particular policy, how the government is taking a role, and then that is the beginning of any advocacy. We are also suggesting that you familiarize yourself with all the international guidelines like you did through this presentation here. Kudos to you all to identify these key areas and continuing to strengthen all of us, including myself. And we ground our lived experience into the real world. So these advocacies are not designed in some big cities, rather inspired and informed by our communities, issues that they're facing on a daily basis. The second step is what we have learned that must be interpreted, translated into policy and power action. So mapping out who our stakeholders are, understanding decision-making process in your community and in your country, and identifying entry points very, very strategically. And I will encourage you to continuing to keep your communication with your Global Alliance technical team. They are a wonderful platform to get into the country decision-making process when it comes to children, adolescents, and pregnant mother. And the next bit is prepare yourself, advocacy pitch. Never underestimate the power of preparation. As you prepare, ask and hold your decision makers accountable to political declarations. They are all signatory bodies. Revisit the country action plans. Look at it critically, applying your lived experience of the ground. Refocus on the communities. Build that bridge between policy and communities. Make sure policies reflect communities' thoughts and views, not the decision maker. And revamp your strategies. Go visit and change as many times as you want to. Do not stick to one that you built together. And then the last bit is, of course, practice plan for impact. You prepare yourself before going to any advocacy like we are suggesting, because institutionalizing communities, bringing community health workers in under the fold of primary healthcare is a significant step that will require us to prepare on all fronts. Various materials will be needed, various strategies will be needed should you take it as a way forward. Next slide, please, Inad. And that is my closing remark. The time to act is now, colleagues, especially against the current political and financial backdrop. Let us act together, and we are here to support any way you want. Back to you, Inat, and thank you for the opportunity, everyone.
Thank you so much, Dr. Muna. And I agree about the time to act is now. The perfect time to ask is always now. It's not in the future, it's not in the past, but it's always now. So thank you so much. And thank you for the 4-point advocacy steps that we have provided. There's an interest in the chat to have those slides to be shared with them because it's useful for advocacy. But I'd also, if you allow me, I'd also like to add one last step, number 5, continue supporting the community for the advocacy to run. I think that's my last step, but thank you so much. We have a lot of questions in the chat, conversations from the community, and I engage you to continue sending in your messages. And as what Dr. Muna has mentioned, the lived experiences should always be the foundation of any advocacy, and that's why our next 2 speakers are I can say one of our most important speakers for tonight, because they will highlight the experiences in translating their experiences in working at the country into policies, and vice versa, translating policies into experiences. We have invited several speakers from our community, leaders of their leaders at the country level, and leaders of their initiatives So I'm now going to call Medea from the Eurasian Women's Network on AIDS. There are several questions that I have asked you, but I think the most important questions, and you may choose the point that you want to address, but if you can share from your experiences, the risks of not putting the leaders, especially the women living with HIV, as a leadership role in the response at the country level. And how do we make sure that there is that leadership role of women living with HIV, especially now that the integration is happening at different countries? Over to you, Medea. Thank you so much.
Thank you so much. I hope my voice is clear enough. It's hearable. I'm really grateful that you gave the opportunity for us to be once more part of this meeting. And I pretty much think that the previous one, when I had the small intervention regarding the tendencies, the trends of obstetric violence in the region, is pretty much kind of the continuation. And what I would like to say would be very easy for me to build up my ideas now after such a great presentations with these messages regarding the importance of the community engagement. Yes, I represent Eurasian Women Network on AIDS. Myself, I'm based in Georgia, Tbilisi. Why I mentioned that, actually the organization is registered in Georgia. And regarding the risks of somehow losing this momentum process, is pretty much now depends also where you're situated, and that might be of an interest to share as well. Regarding Eurasian Women Network on AIDS, many of you might know this network, many might not. I just want to say why I love this network, because it really is based on the skills, knowledge, and experience of its members, situated in the 14 countries of Eastern Europe, Caucasus region, and Central Asia, which you will understand how diverse it is. There are lots of different approaches, but usually what we try to do is like share the experience, navigation information, and then build the advocacy on it. And when you ask the questions regarding what the experiences might we share on behalf of the network, the first thing that came to me, it was asking our members, for instance, from Ukraine, that has been mentioned as one of the good examples in regards of pushing the triple elimination on place in respect of community engagement, also Armenia, but unfortunately our members were not available to be here, so I have the voice instead of them. And yes, there has been the number of very successful cases, and because of community leaders' engagement in the process of advocacy, and not only as a kind of seeing the community members as the beneficiaries, rather the co-designers of the planning and validation process. But I want you to understand that all these risks, actually, what we see is that sometimes this integrated approach we want to build might stay also as invisibility, how to say, dimensional, the trend, because it would stick only to biomedical indicators, totally dismissing the life experiences of very diverse group of women living with HIV, and that's the biggest risk. So if we want those policies to be as integrated, as inclusive, at the same time built on the meaningful engagement mechanism, we should ensure the community voices there. And we, as I mentioned, we already have very good examples at the country level when this led to a very successful validation process. And not only that, I would say that another thing that kind of the systemic change we would like to see is a community-led monitoring as a tool to understand how the process works. Also having in mind that sometimes even the successful cases, because of the political changes or the changes in the accessibility to resources might step back. And here I come to the main question, which is the risks. And I would like you to understand, even those successful cases we have, how they can be achieved. What's the background to work? And this is pretty much now all about even not the funding cuts, very much increased risks of the frontline advocates who work not on HIV per se, but human rights, gender issues, anything that relates to people's autonomy and social justice. This is pretty much the trend in Eastern Europe and Central Asia for now, unfortunately. Moreover, like Eurasian Women Network on AIDS, number of the organizations who have a huge contribution to a HIV response in the region were registered in Georgia. And you to understand now we are under the influence of so-called Russian propaganda of the international influence. So any organization, civil society advocates who work in the human rights defender direction, even if like related to services, we're kind of under threat. And sometimes it's no legal possibility to operate as a registered unity. And there are a number of the regulations and the laws that actually fully control the actions if you're visible. And as I said, that affected only not the Eurasian Women Network on AIDS, rather than all the registered. And there are different levels of ways of pushing this laws in practice within the region. But yeah, this last happening regarding Georgia had a very huge influence on the total, how to say, regional HIV response dynamic on the top of the funding cuts. Another aspect of the risk that I would like to mention is also now the lack of the possibilities of engagement, multi-sectorally engage with the decision makers on the governmental level. So even with the countries like Georgia, and it would be easier for me to speak on that country behalf because I'm part of this community here and representing women affected by HIV community. We had very good collaboration, very successful cases. One of the countries, actually, the pilot countries for triple elimination was Georgia. But nowadays, we found ourselves in a position no longer being that efficiently and safely engaged and bring the voice as a community to the governmental institutions. Even though these experts still work there, and on the personal level, we do have and share this, like the desire for commitment to push things forward. But officially, it's not that safe, and officially, it's not that handy to proceed in the way we used to work. Why I'm trying to bring this example? So we might have very successful outcomes in some of the countries, but unless we act now, as all of us mentioned, to keep that and fix that in the biggest political decision-making way, we might have these horrible backslides. There were the cases we never thought that backslide could have happened, but it still happened. So this is another thing we need to keep in mind. We need to be very cautious about all the happenings, beside of HIV dimension per se, besides the dimension of sexual and reproductive health and rights being one of the primary strategic directions, rather than what happens when it comes to generally community engagement, human rights agenda, gender equality, as was mentioned, because all of the things will directly affect the process we build as a part of HIV response, especially when it comes to us, to the groups that had been stigmatized, criminalized on many grounds even before, not to now being demonized as part of being like networks, local CSOs, or some kind of even informal working groups. yes, these are the risks for now. These are the challenges where we face. On top of that, the region is pretty much affected with the war conflicts. So even the countries I mentioned where we had successful cases, you to understand, we're pushing this through. Our local partners, amazing community leaders from Women Empowerment Center, for instance, again in Armenia, or Positive in Ukraine. But they handle these everyday challenges through the war conflicts back then, right? And in Ukraine even now. And they're dealing with this dimension of the huge migration and the place where this sometimes the national systems of healthcare do not function, great function. And still those you yourself understand will deal with the services they don't wait. It should be done at the moment. So again, keeping that different social dimensions in mind that definitely affect the quality of provision, it's also important to keep in mind. This is about the risks. Now, taking all those risks into account, what's been mentioned by the previous speakers, and some dimensions are added myself. What can be the structural changes we need to look through and maybe act now to somehow jointly lead to the momentum again? It's like building political will, the national and the regional level as well. So not look at us only as contributors to HIV response, rather than look at us as the members of bigger movements, not only women and feminist movement and human rights movement. This is the first and utmost thing to remind us all the time. Second, this change we would like to achieve for now is to understand the potential funders, that the systems of funding, the way they work in the Eastern Europe and Central Asia before, wouldn't work. So we need to think about go out of the boxes and think about this kind of parallel structuring of community engagement, where sometimes in some of the countries, they're not directly engaging with the governmental institutions. And this is totally new type of advocacy or information and skill building. But yeah, we're dealing with that challenge and we're thinking in that direction. And finally, we mentioned this intersectoral solidarity building. We're still pretty much depend on our might still have the influence of our national government within the region, them to kind of bring us into the direction as a basic allies for the community that would lead to the environment where the autonomy, the social justice, and the welfare of every individual counts. Only that systemic environment it's possible to achieve the well-being of the every individual who brings children and the children who we want to have this bright future. This is in a nutshell. Yeah, I do understand it's quite general, but if there would be some questions regarding their country-specific context, or you might want to have more internal information regarding some of the processes, national, related in different country national context again, I would be glad to answer them now in my capacity or link you to the community leaders from those countries. Thank you once more for this great opportunity.
Thank you so much, Vidya, for those points. And I think it's important while learning about the guidelines, learning about the concentrations in the implementation, as well as the recommendations to address the barriers at the country level. I think your points about the criminalization of the community at the country level, having that government agenda, having the government run everything, and the communities are not safe. And the communities are not able to proceed strategically as how they envisioned the program should look like. And that social political environment is actually impacting the quality of advocacy and services at the country level. And I think it's important to also understand what you have said earlier, that the model of funding for communities that has worked before is no longer working.
Hi, Inat. I
I
think
think
we have.
Now, because of the different political factors that are. I'm still here, yeah. Sorry,
lost
did
you
I freeze? I'm so sorry.
Yeah, 1 second, so just keep going.
Thank you. Thank you so much. This networks are not stable, so thank you so much, Florence. And now we're moving forward. Let's call on our colleague Gloria Nwaniaga.
Thank you. Inat, keep breaking. Good afternoon. I think, Gloria, you are here now.
Gloria, are you on?
Yeah.
Yes, I'm on. Can you hear me?
Yes, we can hear you. Just a little bit of a background of why Gloria is here. Uganda hosted the first triple elimination conference a couple of weeks ago. The triple elimination of vertical transmission of HIV, hepatitis, and syphilis. And Gloria being in Uganda and in her capacity as as the lead of the Global Alliance Champions, the Global Alliance that Muna has talked about to end AIDS in children, was there in the Uganda conference and will be sharing with us some of the reflections from that conference and the work from the Global Alliance. I believe that's what you're doing. So please go ahead, Gloria, and Inat is back. Yeah.
Okay, thank you so much, Flo. A good morning, good afternoon, good evening. My name is Nwaniaga Gloria from Uganda. And just like Florence has said, I am a Global Alliance Community Champion to end AIDS in children by 2030 from Uganda, and also the coordinator for all champions in Africa. I'm also the founder of Gilo Young Positives Foundation, which is a youth-led charity organization which empowers, educates, and equips young people to improve their livelihoods and well-being. Let me just dive right into the presentation, and I'm going to be entirely speaking about the Triple Elimination Conference that happened from the 21st to the 23rd of July last month. Next slide, please. Okay, so I think Mona has extensively talked about the Global Alliance Community Champion, rather the Global Alliance. So I won't really, spend a lot of time talking about this. Next slide, please. Okay, so I'm going to give the reflections, just like I said earlier, on the Triple Elimination Conference. This was the Triple Elimination Initiative aims to eliminate mother-to-child transmission of HIV, syphilis, and hepatitis B by 2030. And it was the first ever Triple Elimination Conference held. It was held at Speak Resort Munyonyo, just like I said earlier, from 21st to 23rd of July. And I brought together different stakeholders from different countries to accelerate progress towards eliminating MTCT of HIV, syphilis, and hepatitis B. Next slide, please. Okay, so this high-level conference brought together ministers of health, global health organizations, research institutions, donor agencies, civil society, and the major objectives were to basically share country experiences and innovations around the triple elimination, identify different gaps and solutions to service integration, mobilize resources and political will to eliminating the triple, to achieving the triple elimination, and also promote the adoption and the implementation of the AEVT plan by 2030. Just like I said earlier, it was the first ever, and it was under the theme of integration, equity, innovation, and sustainability. Next slide, please. Okay, so I'm going to talk about some of the innovations and new technologies that were talked about at the Triple Elimination Conference. And there was a conversation around dual and triple rapid diagnostic test kits at antenatal visits. And these duals basically can test both diseases, that is either HIV and syphilis or HIV and hepatitis. And then the triple one can test all. And this conversation was led by researchers like Abbott, companies on pharmaceutical companies like Abbott, SD, SD, Biosensor, and others, and they were trying to see if they can come up with a kit that can test all the two diseases that are identified in triple elimination. However, there is progress, but it has not yet fully. These kits have not yet been fully approved, but there is tremendous progress in achieving these test kits. There was also a lot of conversations around AI for demand forecasting and supply chain optimization, and this was a conversation that was led by one of the doctors from Malawi, who said that they are using a lot of AI to identify the different challenges when it comes and different gaps when it comes to triple elimination, but also come up with different solutions to address these challenges. There was conversations around affordable, high quality hepatitis B treatment. Of course, most of us know that hepatitis B treatment has been a little bit expensive, and there was advocacy around affordability and high quality of the hepatitis B treatment. Digital platforms to track and support patient journey, and still this is a bit connected to AI and the use of digital platforms like smartphones, apps, and all that, to make sure that at least they can track the progress in patients, but then also support their journeys. Then community-based diagnostics and decentralized care. We all know that communities should be at the center, and this was a very huge conversation because at the end of the day, most of these things are done for the communities, so communities should be at the forefront and should be put at the center. Next slide, please. Okay, so what are some of the commitments and policy reflections? The African Union Strategic Framework encourages integrated PMTCT care. We had national pledges and commitments. You can see some of these photos on my right. On my right side, we have the Vice President, High Excellency Jessica Alupo from Uganda, and our Minister of Health, who was actually reaffirming the commitment of Uganda to make sure that we do achieve the triple elimination. Then we also have donor alignments. We had World Health Organization there, PEPFAR, UNICEF, UNITAID, that were also able to reaffirm their support. We had local manufacturing and harmonized regulatory processes promoted, just like I talked about the pharmaceutical companies. In Uganda here, we have QUISL, which is a quality chemical industry that extensively talked about the products they are having, and also the production of ART in Uganda and Africa-wise. And of course, some of the conversations when it comes to local manufacturing is that we should, come up with policies that can favor local manufacturers, but then also encourage more African countries to adopt the local manufacturing companies and support them in any way so that they can produce some of these products. Elimination recognized as cost-effective versus long-term disease burden, which is very true because when you eliminate something, that means you can't spend a lot on it. So there was a conversation around elimination as a concept of something to front and prioritize elimination over the long-term disease burden. Next slide, please. Okay, so these are some of the lessons learned, and of course, most of us know that even World Health Organization and also UNICEF, had a conversation around integration. So there was a big topic around integration, which is very true. Integration is essential for sustainability and equity. Community involvement must be structured and resourced. Just like I said earlier, communities should be at the center. Innovation needs enabling environments and investments. Elimination goals are visible with strong accountability. So accountability is very, very key. Partnerships across sectors increase resilience and research. And most of, just like I said earlier, this conference brought together different stakeholders, different partners globally, not only in Africa, but globally, which really promoted our partnerships. And we do really hope that this partnership will increase resilience and also increase the reach. Next slide, please. Okay, so what is our role as PLHIV lead advocacy groups? One of our roles is to champion for community-centered service delivery. I think I've been talking about this for so many, times. I hope you don't get tired of me saying that communities should be at the center, communities should be at the front. Communities should be at the front and at the center. So whatever service deliveries, whatever products that are made, they should be community centered. Number 2 is to strengthen referral networks and peer support systems, promote awareness and destigmatization and engagement. We also realized that there is actually a lot of stigma around syphilis and hepatitis, much as we, always say that there is stigma around HIV, but also those other two diseases hold, quite a big, they have stigma, around it. So we should promote awareness and also make sure that those other two diseases, that is syphilis and hepatitis, people are aware about them and they should not stigmatize people who have syphilis and hepatitis as well. We should bridge the gap between policy and grassroots realities. That is why we always say that communities have to be meaningfully engaged and meaningfully involved, so that in policy making and also in decision making, so that we bridge the gap. Most of these policies are made, but communities are not involved, communities are not aware. So we should make sure that we advocate to bridge that gap. We should advocate for inclusive national plans and funding priorities. I had conversations earlier, I think from the previous speaker who was talking about the funding cuts. It is very true. We have, funding cuts, but we should also make sure that we advocate for, national funding and also be inclusive with the national plans and funding priorities as well in the national budgets. Next slide, please. Okay, so these are some of the recommendations moving forward. Scaling up integrated maternal and child health intervention, train and finance community health actors, invest in diagnostic and preventive care technologies, secure domesticated resources and reduce aid dependency, just like I said earlier. Then align policies with global strategies and implement them locally. Implementation is very, very key. The fact that there are so many guidelines, there's so many policies, but sometimes these guidelines and policies are not implemented. So we should work on advocacy around implementation of these policies, but also the commitments these policy makers do, and the big people, let me call them the big people for lack of a better word. On the right, you can see our minister signing this commitment paper, and it's upon us as communities to make them accountable so that they implement their commitments, not just signing on them, not just making them, but implement them locally and nationally. Next slide, please. Okay, so these are the final reflections. The triple elimination is a path to healthier generations. The 2030 target is possible with unity, purpose, and innovation. Let's turn commitments into tangible outcomes, just like I emphasized earlier. Communities must lead, governments must act, and partners must support. Lastly, I want to thank GNP Plus for supporting me to attend this conference, and thank you so much. I think the last slide is to thank you all, and to also address to direct you to the website for the Triple Elimination Conference for those who want more information. There was a lot of information. This is just a summary. I've been reaching out to Ministry of Health, our ministry. Technical support team, and they're telling me the report is not yet ready, but hopefully when the report is ready, it will be shared worldwide, and you can look it up and get all the details. There was a lot of research that was shared, there was a lot of information that was shared. So this is just a glimpse of what was put out there in the conference, but you can go and look them up on their website and then also on their X handle, that is former Twitter. Yes, thank you so much, and back to you, Enid.
Thank you so much, Gloria. It has been a wonderful session tonight. But before we proceed with the questions and answers, I'd like to call my colleague Helena to have your floor to take a photo of us all. Helena.
Good afternoon, good morning, good evening, depending on where you're joining us from. Thank you so much for making time to join us. And I would like to take pictures for all the leaders today here. So it would be great if you can just come on the camera and give me your best smile as we continue discussing these issues around ending HIV. Yes, Flo? Continue.
You want to stop like highlighting yourself? What is it, spotlighting? Or...
Oh, on my side, can you see me?
Could we, so that we have it on screen? Yes. Yeah, but you're spotlighted, so you're filling the whole screen. So remove yourself so that everyone is on the screen.
Oh, but on my side, you are all on the screen. Should be a setting, but okay.
If you can see us on your side, that's fine.
Yeah, I can see everyone on my side. Kindly just continue coming on the camera so I have more people before it goes. Thank you. Great. Just continue coming.
If you can put your video on, please do.
Yeah.
We'll just second.
Nelson, are you able to put your camera on, Anchor? I'm just calling those.
This video of mine often refuses, so if it refuses, just proceed.
Okay.
Technology, Nelson, thank you so much for letting us know. Great. Okay. Eva, are you able to kindly put your, great, thank you so much. Welcome all. Okay. Hi, Conso. Great. Okay. Over to you, Inat.
Thank you so much. We are over time, but thank you so much for still staying with us. If you have 5 to 10 more minutes for just some questions. So there's one comment here at the chat from Nelson saying that community engagement will need to be redefined further at country level. Some countries, government think community only include community health workers who are actually lower cadre healthcare workers. By community engagement, we mean recipients of care with an entry point from PLHIV. Dr. Rislan or Dr. Muna, would you like to have a comment on that about community engagement and how it should be defined further?
Yeah, I think it's a very good point. So was asked. So, and I think when we define the community engagement, so I don't think we'll have the definition which will be one size fits all. So, and it will be defined on specific situation in the country. So, and as we heard from a presentation that in Ukraine, or Georgia, there's a civil society faces specific challenges, so the definition probably would be different from some other parts of the world. So, but of course, I mean, there should be some common denominators, so and some key principles, which would guide. So, but again, I think the specifics would be, I think, within the countries, so to define, which exactly the models of engagement sort of be surveyed.
Thank you. And I think that, sorry, go ahead. Oh, okay. No, thank you. And I think that kind of like re-emphasizes how the communities define integration and define community engagement as well at the country level advocacy. There's one question, and I think I'd like to ask Dr. Nanita if he's still here. Dr. Nanita, are you still here?
I'm still here.
Oh, yes. There's a question from Randy Davis. Although someone has already responded, but I'd also like to hear from your perspective. What strategies are in place to ensure retention in care following diagnosis and treatment initiation during infancy?
Wow, that's a great question. That's actually a big issue. That is one of the biggest issues, is that we don't have great retention of the mother-infant pairs. And I think this is, there are multiple reasons for this. Part of it is we don't give special attention to this pair, right? So we're usually following the mother someplace, and then the child has a separate file. We also have to remember that the exposure period continues throughout the breastfeeding period, but it's not to say that breastfeeding is dangerous, right? So we want to make sure that we're balancing the message based on what we have. I think it's important for mothers to understand. I think a lot of this is treatment literacy. One thing I sometimes look at in programs is they will very often report the number of infants who are diagnosed positive on the 6-week EID test, but we don't hear how many actually return for the 9-month test. And we know that's important. We have still fewer that come back at 18 months. Now, I think some of the discussions around integration, I think, is really particularly valuable for EMTCT because there are actually many touch points in the first couple years of life through and for both mother and infant, right? So there's the immunization schedule, there's maternal postnatal care. So I think we need to tap into some of these additional services and make sure that we're providing what mothers need most. And I think that was the important part of that recommendation for breastfeeding, is that all mothers deserve that support, right? To optimize infant feeding and breastfeeding in particular, which is really challenging, and to retain and to be able to bring their child back for regular routine health visits and immunization, and really have health providers who can provide treatment literacy, right? I think what we really want to make sure mothers are able to do is make informed choice, and that really requires them to have the information. So I think it's critical as well. I mean, just to go back to the first question around community, is also making sure that what comes from the policy level actually makes sense to people. And I think there's the point that was made about how there's really a big gap sometimes between policy and what's on the ground. I think we have to close that gap, right? And so some of that is through literacy and treatment literacy and education. I think for mothers who are new, especially mothers with young infants, they're the ones that really need help. We know that it's not an easy time of life for anyone, regardless. But I think the health system needs to be supportive. And I think this is the best start to life, right? If we do this right. So I think integration is a key point that we want to think about for EMTCT. Thanks.
Yeah. Thank you for highlighting that. And I think Dr. Muna would like to say something. She's raising her hand. Okay, go ahead.
Thank you. Thank you, Annette. I will take very quick few seconds just to support Nandita's submission, but to build on it. Integration is a white elephant. How we are going to interpret integration really depends what background you are pouring into it, right? What's the framework you are sitting on? That's how you are going to define integration. I think the problem of the current structure truly is that it's very biomedical. We are not looking at some of the key critical elements, like Nandita said, viral suppression of moms are the biggest critical area of success for elimination, triple elimination. If that's the case, viral suppression doesn't mean medicine alone. It means the whole environment a mother is in, how much support the mother is getting. Is she a subject of GBV, for example? If she is pulled into some of the household chores where she has no support to get those medicine, if she is continually hiding her status, hiding those pills under the banana leaf next to her house, that we know very well, those who are on the ground, is happening for many women, then forget about viral suppression. It's not happening. So it's not fancy clinics. And that's why we are proposing from the policy report that truly make those community health workers very integral of the health system. If you are living with HIV or a community health worker, you do understand the importance of these mothers, you understand their daily realities, and integrate them in a way so that viral suppression is achieved not through biomedical support, making fabulous clinics and everything, but also, in addition to amazing health workers around those moms to continually support them as need arises. Back to you, Nad.
Thank you so much. And thank you for saying that virus suppression is not only biomedical, but also involves the psychosocial and other environments that impacts the uptake of treatment. This has been a very wonderful discussion, and we are very, very happy. Thank you so much to our esteemed speakers, Dr. Nandita, Dr. Raslan, Dr. Muna, Medea, and Gloria. This has been really wonderful. Before I close and wrap up, Florence, do you have anything to say?
Mine is to thank Dr. Nandita, Dr. Muna, Dr. Rasyan, Gloria, and Medea for your wonderful presentations today, to everyone on the chat actively engaging with these conversations. Thank you so much. I see your question, Milfa. We are always convening here every 2 weeks. I've seen your email. We will include you into the mailing list. We bring topics. This is our space to learn from each other, to share across topics, to share across region what's happening. We are in a different environment. We are in a time of change. And what will get us there is when all people living with HIV, together with all our partners, allies, policymakers, come together to think together of a way forward that will be responsive to our needs, that will promote our leadership now as people are planning and shaping and reorganizing, but that will create a landscape from which our leadership can pass on to the leaders that are coming ahead of us. So mine is to thank you all. See you in 2 weeks. We will share the recording. We will share the presentations. Inad is here. Should you have any questions or want to connect differently, we also have a WhatsApp community group. Do email us at community@gnpplus.net. Inad, put your email down there. Inad will be there to welcome you. And thank you so much. Back to you, Inad.
Thank you. While I'll finish the chat. Thank you so much, everyone. And we are very happy to see everyone after the conference. So many familiar faces here. Thank you to all our speakers. We will share the slides. Of course, with the consent of the speakers, we'll be sharing the slides. Keep in touch. See you in the next 2 weeks. Good night, good morning, good afternoon, wherever you are. Thank you so much and take care.